Good evening, everybody. Welcome to the 23rd episode of the 4D program. And I think we have a very exciting session today. With us, we have Dr. Neeraj Manikandan, who is from the Calicut Medical College from the Department of Internal Medicine there. And today, I think what he's going to talk to us is about the problems associated with diabetes care in India. And I can really see there are lots in my practice or even in the community. Currently, we know that there are about 77 million people living with diabetes in our country. Of them, I think the first problem is only 50% of them know that they have diabetes. So that means we have a problem with screening. We have not even picked up half the patients with diabetes who are there in our country. The second problem is even among those 35 million odd patients who know that they have diabetes, only 50% of them seek medical treatment. That means only half of them are seeking medical treatment. So I think we do have a major problem. And even those who seek medical treatment, whether it is a tertiary clinic or a primary center, a health center, or a secondary health center, my guess is only about 15% to 20% of them have what we call satisfactory glycemic control. That means they meet the targets of about 7%. So I think there are a lot of problems associated with diabetes care within our clinics, within our communities, within our country. I think there is no better person than Dr. Neeraj, who is going to talk to us about the problems associated with diabetes care in India. So, welcome, Dr. Neeraj. And I think we will start with your presentation and then follow it up with a few question answers. So, welcome.
Thank you, Professor Jibin Jacob, for those kind words of introduction. Exactly as you had echoed, I think the sentiments are the same on my side too. Can you please project the slides, please? Thank you. So, over the next 5 minutes, I'll be just rushing through the problems associated with diabetic care in India. I think it's not much different from any other recently developed nation. Next slide, please. The problem faced by Indian diabetic patients are multifold, actually. So if we grossly look at the problems, is that there is a lack of general awareness on the diagnosis of diabetics. As Dr. Jagan has rightly pointed, that 50% of the diabetic patients are not aware that they are having diabetic. And it's much worse case scenario than the hypertension, where the rule of 50 was there, where 50% didn't know they have hypertension, 50% who knew they didn't have target. All this. It's much worse in diabetic, I would say that. Even people who knew they were diabetic, I think more than 80% are not meeting the targets of adequate good diabetic care. Along with that, the diagnosis is an increasing problem, especially in the rural areas, actually, because of the access to medical care. And then there are financial constraints, especially more so among people who go for manual work. And there are social barriers on treatment, and especially if somebody is diabetic at home, it's very difficult for them to cope with the rest of the family who take the normal diet. And the concept of a medical nutrition therapy is almost virtually non-existent in India, I would say. So it's one extreme, the people eating normal food, or I won't say it's a normal food, but the other person who is a diabetic denying the rights of a proper nutrition and facing nutritional challenges, and still his glycemic targets are not met. Next slide, please. And you can see the distribution of cost as far as India is concerned. This is a major concern, especially for the working class people who don't have the access to insurance. They may have to bring out the money from their pocket for their care. And also, you may know that many days are lost in a diabetic due to comorbid illnesses that develop in a diabetics. So this is a split of how they are spending on the diabetic care. Next slide, please. So let's briefly go about the barriers that are there in treating diabetic in the Indian context. There are patient barriers, there are physician barriers. And looking at the patient barriers, the major thing is lack of awareness and poor compliance with treatment. And the thought that his diabetic is not a diabetic, not the diabetic that you see in the neighbor who has all the complication, and he's immune from all those complications because acutely he doesn't have any complication despite having a poor glycemic control or a 300 or 200 blood sugars. And then there's stress, fear, and confusion of treatment and the treatment, what outcomes of treatment, whether renal disease is going to come with treatment or without treatment. So many people tend to think that the disease treatment may predispose him to complications of diabetes. And then when you treat a diabetic, you don't immediately see any benefit. When the blood sugars come from 300 to 200, you may not see a immediate benefit, and the patient doesn't know what it does translate to. When I don't see an acute benefit, why should I go on taking a medication like this for lifelong? And then, of course, as I told earlier, lack of family and social support. Because once diagnosed, he is given a separate nutrition, separate diet, which is and told by when by treating doctors what all things he should not eat rather than what all things he should eat. So it's immediately a deprived diet that he is upon. And then lack of trust in doctors is always there, especially in Indian context where polypharmacy is there. A lot of alternative branches of treatment are there. Polypathy is always a part and parcel of Indian diabetic treatment. Unless if you ask, patients may not divulge, but we have done small studies in our diabetic clinic and found that 90 to 99% of diabetic patients attending our diabetic clinic are taking alternative medicines as well. Only thing they fear to divulge for fear of rejection. And then, of course, lack of adherence to the guidelines and targets. People don't know the targets actually. So though they repeatedly come doing random blood sugar, and then the drugs are titrated up and down. They go ahead doing random blood sugars which are of no use, and they don't know what their targets, what are they chasing. So these are the patient-related barriers that we face. And coming to medical professional, physician-related barriers, there are training in diabetics, but lack of good training in the chronic manageable illness segment is, of course, very much there, because as doctor has rightly pointed, it's not in the secondary care or tertiary care that most of the chunk of the people with diabetes go. They go to primary care, the PHCs. So although there is an extensive network of PHCs in India, the manning of these PHCs are not by people who are adequately trained in diabetic and hypertension care. So they're trained in acute care, but they are not trained in very well in chronic care. And many of them might be specialists in some other sub specialties of medicine, and not a doctor who has trained himself in comprehensive diabetic care. And also coming to physicians, also we see that acute care always is more rewarding, more practically embraced by most of the youngsters who pass out, rather than chronic care segments like hypertension, diabetes, malignancies. Next slide, please. So what are the therapeutic strategies that we can do to overcome these barriers? The most important thing is the novel medication therapy, usage of combination pills, rather than going for a single pill or a new pill or a costly pill or an injectable. Going for combination medications right from the start and adhering to the regime and altering the regime when we are not meeting the target are the most important thing. And this should be started right early and adhered to, and the patient should be a member in the treatment, and he should have his own decisions pouring in when you decide to change a drug or hike a drug. So I think these are the major points that I would like to make in the short presentations on the Indian context of diabetes. Yeah, the other things we could do are, of course, patient education and empowerment. As I told rightly, we always need the patient to be part of our treatment decision making, rather than the doctor or the bystander along taking decisions on what the patient should eat and what the patient should have as medicine. Patient should always be part of that, the entire team, and should have innovative words to say where he can also be a part of the decision making. So also telemedicine strategies. Right through the COVID, we have seen that telemedicine strategies work excellently well, especially in chronic illnesses where you don't need to do a routine physical examination from head to toe for a diabetic patient every time he comes. You need to talk to him, you need to grossly look at him. You need vitals, of course, but that can be got in telemedicine in telemedicine by using paramedics. And then you give opinion to the patient, you give what dietary modification need to be. So every time the patient need not be in front of you, coming from 20 to 30 kilometers away from his home to a hospital, risking his day's job and earnings. So he can contact you telemedicine. And with the widespread of telecommunications in India, it's hardly, I think most of the people would be having a mobile phone and access to internet. And even if it is not there, healthcare workers can go to their home and do a telemedicine consultation through them, actually, through the paramedical staff. The nursing staff who go to their home to collect data, they can have the telemedicine consultations if they are given the good equipment with telemedicine facility. The voice has gone.
Thank you, yeah. Dr. Neeraj. That was very short, but you told us what can be done, what is possible. So I think we'll quickly go into our question and answer session. So my first question is, as a country, we are considered a middle income country by WHO, but we still have huge pockets of poor or poverty in our country. And we have huge pockets where patients or where people are not getting enough food. They are malnourished or undernourished. Despite this, background, we are still considered the diabetes capital of India. Do you have any thoughts on that?
Yeah, I think rightly, as we had pointed out earlier, if you go to anywhere in the world, I would say that India contributes to 17% of the world diabetic population. So, say, for example, if you look at 15 plus age population, 10% of Indian urban and 3% of Indian rural are diabetic. And as you told, 50% of these people are unaware that they are diabetic. And this contribution, looking at the huge population of India, would be a huge chunky number. And as you told, the malnutrition and diabetics is an interesting story in itself. We know that when you are born with a low birth weight, your beta cell mass suffers due to newborn malnutrition, and then you are at high risk of developing diabetes when you become old because of the already challenged beta cell mass. And that's as far as pathophysiology goes. But looking at the community, when you say that there is malnutrition in India, I wouldn't say that that malnutrition is in the calorie aspect, actually. Maybe 20 to 30 years back, there was calorie malnutrition. But now what happens is that malnutrition is not there in calorie. It's in the specified nutrient aspect there. So people consume large amount of carbohydrates and cereals, especially from the Indian context, which makes a glycemic load for these people who are already challenged by the previous malnutrition. So I think that is a big contributor, especially in India and China, which had faced malnutrition, famine and all those things a few decades back, and now is in the path of recovery and affluence, actually. So the poor dietary habits are the major things that has to be blamed on one hand for the rising number of diabetic and being the diabetic capital of the world.
So if I have to summarize what Dr. Neeraj said, was because of our sheer numbers, we are the diabetes capital because of our population itself. And because of that, we have sheer numbers. The number two, what Dr. Neeraj specified was malnutrition in itself, especially malnutrition which happened maybe 3 decades back or 4 decades back, when where the current patient today was in the womb with a mother who was malnourished. That itself may be contributing to the diabetes that we see today in those 30-year-old, 40-year-old offsprings of those malnourished mothers. The third thing that I could realize, that what you said very correctly, is malnourishment is not just not having enough calories. It is also consuming too much of one macronutrient. Maybe it's in India, I think, whether it is in the south where you are, or whether it's in the north where I'm working, we know that we eat too much of carbohydrates. So that is also part of malnourishment. Almost 80% of our total calories come from carbohydrates. So I think you've made 3 very valid points. One, by population, we are a large population, so we have a large number of patients with diabetes. We had malnourishment 30 years back that may be contributing to the current crisis. And thirdly, that despite the fact that now we may not have that degree of calorie malnutrition, but we still have what we call macronutrient malnutrition, or what we call underutilization of certain macronutrients and overutilization of some. So I think with that, my second question to you is, things are bad, as you have pointed out. Is there any way we can do better in terms of preventing diabetes? I think globally, whether it is various parts of the world, they have tried different programs. But what do you think is the current situation in our country to try and prevent development of diabetes? We do have these risk factors in our community right now.
Definitely, I think primary prevention should be the target, especially for chronic illnesses like diabetics, which has caused a lot of complications downhill when you have 10 years down diabetic. So if you can aim a primary prevention strategy, that is best. But as far as I know, in India, there are certain primary prevention strategies that has been placed, but they are very rudimentary, actually. So I think we need to be on a large scale, massive scale, right from health education in schools, where the need for physical activity, the need for calorie restriction, the need for a good ideal diet that they should consume should start right from school time and should extend through college, and that should be part and parcel of their lifestyle when they come out as working productive people. So unfortunately, that is not so. Time and again, we see people even educated people doesn't know about the nutrition, the foods they consume, the risk of foods they consume, and the food heating habits they should adhere to, and the principles of how a patient obesity, the relationship between obesity and diabetic, and all those things. And that's why you can see that if you look 10 to 20 years back and now, the number of children coming with unrelated illnesses, you can see there's a huge change in the body weight of these people actually. So, for example, 10 or 20 years back when I started my practice, I see children being brought with fever. I routinely look their weight. They were 10-year might have a weight like between 10 and 20 kg, or say 15 to 18 kg. But now suddenly, for the last few years, we are seeing people of the same age group coming with 40s, weight coming as 40. So actually, an obesity epidemic is raging in the country. And if we don't do something right now, we are going to have still huge numbers of diabetics. And once a patient develops diabetics, half of our effort is lost already. So I think the focus should be more on primary prevention, and that would be very fruitful, because a disease prevented is going to help GDP, consumption of GDP by a huge numbers, and going to have healthy individuals living longer without diabetes, something which is very rewarding, I think. So I think we should more focus on primary prevention rather than on disease control and disease comorbidity reduction and mortality reduction.
So I think I'll summarize for you. What we
Yes.
do know is, I think what we have known for almost 30 years from studies is that lifestyle prevents progression of pre-diabetes to diabetes, or progression of a high-risk patient who's likely to develop diabetes into diabetes. Simple lifestyle. I think we have known this now for almost 30 years from the DPP program. We have known that this works in the United States. We have known this works in Finland. We've also known this works in India, because there is an Indian diabetes prevention program as well, which showed very well clearly that lifestyle measures, you don't need drugs. You can take drugs. There are drug trials also, but simple lifestyle can prevent. I think very recently I heard the Kerala diabetes prevention program, which is run from
Yes.
Sri Chitra, the public health unit there.
Yeah.
I mean, it's very easily established that we have the tools to prevent diabetes. But unfortunately, I think the ground reality is that we have not been able to use those tools in our community to make sure that we have programs that can actually make an impact. So all these programs are small programs, basically
fragmented here and there.
To establish the science, but we have not really been able to put it into practice and help our communities to develop program that can finally have some impact. So I think my next question to you is, could it be because there is less knowledge, there is less awareness about diabetes, not just in rural India, but also among the impact of that, let's say, among politicians, among bureaucrats who are making all these decisions? Do you think there is less knowledge and awareness about, I mean, I'm sure all of them know about diabetes, but the impact of diabetes, what it has in terms of chronic complications on long-term, impact on economy, impact on social structures. What is your opinion on that?
Yeah, definitely. I think we as medical professionals, we often take our duty of treating patients. I think beyond that, we have a responsibility to the society, where we could give them health education, as you rightly pointed, to people who matters in taking decisions, be it politicians, be it people who are planning board members. So we should, whenever we get an opportunity to talk to somebody, not only to a patient, we should use this opportunity, grab this opportunity, and talk to them about the possibility of primary prevention, possibility of dietary modifications needed, the harmful effects of fast food, the harmful effects of not doing exercise. This should be projected at every moment we get a chance to talk to somebody, rather than to a patient. I'm telling to a bystander or a bystander of a patient, or even to when you get a chance to speak on a podium. I think we should be utilizing that every moment to propagate health education prevention strategies.
All right. So, Dr. Neeraj, now we'll come to, I'm sure your primary job is a clinician, and you are treating patients who come to you. You are doing what you can about education, about sensitizing the community. Now, let me come to an individual patient. Now, an individual patient with diabetes does not just have diabetes. He has diabetes. He probably, most likely, will have hypertension. He most likely has a abnormal cholesterol level for which he requires a drug. So many of our patients are on multiple drugs. and many drugs they are on, and how will you, I mean, many of them will express their inability to not pay for all these drugs. So how do you help them manage their expenses in terms of the large number of pills they are consuming?
I think that question is a little easy for us because I work on a government setting actually. And fortunately for us, most of the commonly used anti-diabetic medications, including insulin, the routine insulins, not the high-end insulins, come as government supply. So once the patient is attending our facility, we have the option of giving them free for them for a month duration. And when they come for a review, irrespective of their financial status, they can get those medications. That's a good thing about it. But the slightly bad thing is that most of the time people come from other hospitals where they are given newer costlier medication, and that may not be available in our setting. And then we have to sit and talk with the patient on the benefits of glycemic control, which is the prime thing that is concerned as far as the diabetes is concerned, and then the pleiotropic effects. So at times we'll have to sit with them, talk with them, especially because many a time when they start the drug, they may start taking the drug, and when time goes on, they may not be able to sustain the cost of the drug. So that's the major concern in the chronic disease segment. Initially, they might be taken by some bystander, some wealthy relative to a tertiary hospital, or a new drug has been prescribed, and then subsequently he has to buy his own drug. Then he can't shell out the money from the pocket, and then he drops out from the treatment, which is even more disastrous than adhering to some basic medications and getting a good glycemic control. So that is little challenging, but otherwise I think for the cost concern, especially India, with the NCD program, the non-communicable disease program, that's run in most states, the government of India is supplying free of drug cost. And also the Pradhan Mantri Yojana is there, wherein medicines, generic medicines are available for most of the drugs, not the newest drug, but most of the drugs are available at a lower price. So that might be a good thing for the last few years as far as India is concerned.
So I think one more place where India has contributed to reducing the cost is in combination therapies. I think let's say
Definitely.
15 years back, if somebody talked about 3 drugs in a pill, they would think it is extremely unscientific. Now, even in the Western countries, there are drugs with 3 drugs in a single pill. So do you want to talk a little bit about this is, I think, Indian contribution, where we've had fixed dose combinations for almost 20, 30, 40 years. We've had fixed dose combination of more than 3 pills. Many of them were not scientifically studied, but it was using logic that you will reduce the cost, you will reduce the pill burden. But I think now Western science has also come to the conclusion that fixed dose combinations are actually easy on the pocket for the patient, and also help in keeping compliance good. And we've now seen triple drug combination also in the Western market. So any comments on that?
Yeah, I think hats off to DCGI for approving such drug combination even before international drug authorities approved such combination. DCGI was generous enough to approve such combinations for Indians actually, and that dramatically reduced their pocket drain actually. And also the pill burden has come down, the compliance has improved. Maybe as you said rightly, it was not rigorously scientifically tested, but in the field we saw that it did work equally well actually, and at more comfortable for our patient's pocket, and for his routine life was a little less burdened actually by number of medicines actually.
I think in India now we have generic preparation of some of the most effective drugs available internationally, a combination of metformin, DPP-4, SGLT2 inhibitors. These are considered all individually considered very expensive drugs in the West. But I think in India we have a combination of these 3, which is available, as a branded generic also, I'm sure will be available soon as generic preparations, which will keep the cost down considerably low.
I think at this point we should change our focus from cost, which has come to be affordable, to a point where compliance and targets are being met to be more important. Because as you rightly pointed, cost is not much of a concern for majority of Indians because of the subsidized drugs that are available and some drugs that are freely available as well. So now we should focus on targets being maintained and kept like that, and also compliance part from the patient.
So I have an odd question. Now this is again, I'm sure as a clinician you might differ from me, but there is a question here that despite the availability of alternatives, we have now triple drug, we have quite effective drugs, insulin is favored. I'm not sure whether this is completely true from my clinical perspective, where patients would rather take 5 drugs than shift to insulin. But in your practice, where insulin is freely available from the government, is there a favor for insulin rather than
No,
using the
I think
newer?
it's almost same like your practice. Once in a while, a patient might come asking for insulin, but otherwise they are happy to take 3 or 4 drugs. And the moment we talk about insulin, they think it as a punishment that is being met to them for poor glycemic control. So, and with the newer options of newer drugs coming affordable and delaying insulin initiation, I think still I don't see a patient every other day coming and asking for switching to insulin. It would be the other way around. I would be going behind him for a few weeks before I could start him on an insulin.
All right. So I think that is, I think, very similar to almost
Yes,
everywhere in
yes,
the
sir.
world. It is because
Anywhere in the
injectable
world.
therapies are generally not favored by patients. I mean, they find it difficult. They find it more cumbersome, and
Yeah.
obviously, they always have that fear that they are injecting something. So that is always there. So there is definitely, even with free insulins, there is a little problem in patients accepting the same. Now, again, another clinical question. Now, you do prescribe drugs, but I think lifestyle equally stays important, not just for prevention of diabetes, but also for managing glucose control or managing blood pressure, managing lipids, and managing complications or development of complications in somebody with established type 2 diabetes. So, would you want to tell us a little more about in your part of the world with your kind of cuisine? How do you talk about diet control or medical nutrition therapy to patients?
The what happens is that whenever I see a patient who is having an uncontrolled blood sugar and I ask about diet, it is an intimidating question to him, and he will come up with a lot of answers as see, I took a payasam yesterday, I took a kheer yesterday, and that's the reason for the high blood sugar. Please excuse me, I'll be a good boy next time and come with that. So I think no, that's not the issue. I just want to know what you have. And many times people say about the major foods they eat, but the snacks they eat are often uh, not counted actually, because they don't think it's necessary. One loaf of bread or one bun doesn't contribute much, and they're in between snacks, and the snacks they have with tea are often not told in the dietary history. And unfortunately, in many of the hospitals, as we know, when a doctor see 100 to 150 patients a day, there is very little time to take a dietary history. But I think before hiking a patient, uncontrolled diabetics drug, it would be worthwhile on pondering for his diet for a few minutes, because many a time instead of hiking the drug and chasing the blood sugars, little dietary modifications due to the misconceptions the patient have can go a long way in decreasing the pill burden and unnecessarily hiking the drugs. So whenever I find a uncontrolled blood sugar, I just take 1 or 2 minutes to chat with the patient. Most of the time, I can find 1 or 2 suggestions in his diet which doesn't curtail him more, which could translate to good glycemic control. And like always, I say my diabetic clinic is in the second floor actually. So the first question I ask them is that, how did you come to the clinic? If they say they use the lift, I think I tell them that this is not the way you should be climbing. If you don't have an orthopedic problem, you should be climbing the stairs, and that would burn this much calories from you. So do that every day, and that brings down your blood sugars. That makes you more healthier, makes your heart more healthier, makes your muscles more stronger. So something like that, which you can incorporate into your routine practice, I think might be worthwhile.
Yeah, so I think I completely agree with that. That my clinic is also on the second floor, and I think it is almost like a cardiovascular test. If you have climbed 2 floors and come to me and you've had apps, you've been comfortable, I don't need to do any excessive cardiovascular investigation. I know you are fine. I mean, sometimes I use that test even to prescribe, let's say, something like phosphodiesterase inhibitors for patients with. I'm very sure that this patient does not have any cardiovascular disease if he can climb 2 flights of
Right,
stairs and
right.
come. So good. So one more question. Other than, do you prescribe any dietary supplements for patients with type 2 diabetes in your clinic? Any vitamins, anything specific, or do you concentrate on just making sure you get all the
Uh,
micronutrients from
as a
diet
part of
itself?
routine diabetic care, I don't give dietary supplements, because if the patient is counseled for a good diet, nothing makes, diabetic doesn't demand extra nutrient support, extra micronutrient support actually. If you are having a balanced diet, just like a patient who doesn't have diabetic, almost all of the micronutrients would be supplied from that. So it comes to occasionally a person who has a micronutrient deficiency. For example, a strict vegetarian, I might be go to the extent, and he's on metformin, I might go to the extent of supplementing him B12. Otherwise, routinely, I don't prescribe nutritional supplements, because that gives a sense of false belief to the patient that this would take care of my ill habits like smoking, alcohol, and there's something in this that would take care of that, so I can indulge in certain activities which won't be of a problem. So unless a patient has a deficiency proved or at risk of developing a deficiency due to his comorbidity, routinely I don't give supplements.
So thank you for that insight. Now, the second last question I have for you. I think this question is, what is the information that a patient with diabetes should have to manage his diabetes? So we can have, there is a lot of information any patient could have, but a minimum set of information. I think along with information, it is important to realize that there is also a lot of misinformation. So we have one side, we don't have patients having adequate knowledge. On the other side, we have patients who have, imbibed knowledge from the wrong sources, from WhatsApp forwards, from, let's say, something they have seen on Facebook or something they have seen on internet, which is completely contrary to the science of managing diabetes. So I think my first part of my question is, what do you think is that minimum set of knowledge that a patient with diabetes should have? And the second part would be, how do you help in counteracting the misinformation that many of our patients are bombarded with?
The first part, I think I always write on my prescription the patient's blood sugar, the patient's blood pressure value, and I put in a square. These are the targets for you actually. So my interaction with you is to make you achieve these targets at maximum comfort for your patient, not to go to the extremes of risking hypoglycemia, extremes of dietary restriction. We want to have a chat, and I want to achieve these targets in the most comfortable manner you can. And that's why you are coming again and again to meet me. And along with that, I would be monitoring for your comorbidities, which are likely to happen and be silent until they have an ugly head. So every time you come to me, these are the things I will be looking at you, looking at your values of A1C, fasting and postprandial blood sugar and blood pressure. At the same time, looking at your food, looking at your fundus and all those things for silent lurking comorbidities that can occur with diabetes. So it's not just the values that matter, it's the values and the person who has that values that matters to me. That is you, the patient with the diabetic. So ultimately, I want you to achieve these targets at the best possible way and the best comfortable way you can have, and make you sail across your life with little comorbidities or delaying comorbidities. That would be my target. The second thing I would say that you might hear a lot of messages about medicines like NMDA inside the metformin and all those things, but make it a point to talk to me before deciding on changing the medication. You can always call me or WhatsApp me. I would give you best of my knowledge that is available. Before you change a drug, before you hike a drug or decrease a drug, make it a point to give me a WhatsApp call or a WhatsApp message, and just wait for one day. And if I don't reply, you go ahead, do that. But before that, don't do anything rashly because of some reports that come in newspaper or media, because there are a lot of information that are happening. I would say a few examples for that. It's like what happened with the metformin misinformation, some things like that as an example, and say that, see, these are the mishaps that can happen with you. You have been a good diabetic, good patient with diabetic and good control. So before you take a rash decision, just make sure that you give me a time where I can discuss with you. And if you feel convinced, you can go ahead. That's what I use.
All right. So thank you, Dr. Neeraj. I'm going to wrap it up by asking you the last question, but my last question is probably the most important question. And the last question is also, I think, where you as an expert, you know that we started off by discussing the current state of diabetes care in India. And we were, you yourself said that the number of doctors who are treating diabetes are varied. It can depend, it may be a physician in a secondary health center, it may be a simple MBBS doctor, it may be somebody who's completely, maybe an orthopedician treating in a primary health center, to very highly super specialist in tertiary care. But I think as an expert, if you have to give a set of recommendations to everyone who is treating patients with diabetes, it may not be just physicians, it may be MBBS doctors, it may be gynecologists who have to manage diabetes because there's no other doctors. What would that be? I think you can take your time here and list out your recommendations for Indian physicians to manage patients with diabetes in India, and try and get the targets that we want.
First thing I would say that do no harm. Whenever you see a patient who is being treated by somebody else coming to you for a different illness, unless you're perfectly sure that the medicines he is taking is doing harm from your specialty perspective of you, please don't change and please don't come in, because that's going to be a disastrous result on that patient-doctor relationship and also maybe on his illness as well. If you have some point, if you have to make a point, you can either discuss with the doctor over the phone and then decide between yourself and then better speak to the patient, because the patient would be extremely confused if some things come out of your mouth and they can't digest it, because last 10 years or 20 years somebody is treating him for diabetic and comes to you, he has some other illness wherein you think a drug might be probably causing or probably worsening the situation, and then you say that this drug is the problem, then the whole thing comes down like a tower of cards. So please don't do that. If at all you think it is genuine and it has to be handled, you can probably talk to that doctor over the phone or give a letter in writing to the phone that what you want to intend to do with the patient, and then change the drug or whatever treatment modality you plan, because otherwise it can be extremely disastrous actually. I think I answered that. The second part of the question was?
No, that is one advice you have for doctors who are seeing patients already being seen by someone else. Now, suppose
Yes.
a doctor sees a diabetic patient for the first time. What are the recommendations that you would suggest to him to manage?
I think India is not at ripe for all diabetic patients to be treated by an endocrinologist or a physician, because the huge numbers are so huge. So I think hypertension and diabetics is what should be the knowledge of treating essential hypertension and diabetic should be a minimum requirement for anybody who is treating any patient, human being, because that's a huge number that we are dealing with, and you can't expect a physician or an endocrinologist to cater this population. And at least for the next 20 to 30 years, that's not going to happen in India. So if you're a doctor and you're treating a patient, make sure you know how to treat diabetic, how to treat hypertension, because they're extremely simple. It may not be every other diabetic is a complicated diabetic or a type 1 diabetic or a ketose-prone diabetic. Majority are routine type 2 diabetics, which are essentially very simple to treat. And when you start treatment, always be gentle, start slow, go slow, rather than starting on a huge, like for example, 200 blood sugar first turn, starting on a glibenclamide 5 milligram twice daily, it's going to be a mishap. So always start slow. Unless you recognize acute dangers or need for hospitalization, don't overtreat the hypertension, don't overtreat the hyperglycemia. Take your time, give the nutrition, nutrition therapy its time to settle, give the patient its time to settle with the diagnosis of chronic illness. Start drugs slowly hike. So that would be the best practice, unless you are dealing with a hypertensive emergency or a diabetic emergency. This should be the practice I would recommend. But I think every person who is treating a patient should have the basic minimum knowledge of diagnosing diabetics, treating diabetics in the primary care setting.
So thank you, Dr. Neeraj. I think we've had 40 minutes of very fruitful discussion where we have, I think you have well established why there are problems that are associated with diabetes care in India, why 50% of our patients are still undiagnosed, why many of them are still not approaching doctors, are ignoring their diabetes and not getting the treatment, and why even when they are getting treatment, they are not on targets. You have highlighted the need for a good diet. Now, the good diet is both for prevention of diabetes and also for managing diabetes. You have also highlighted that there are plenty of drugs that are available which are generic, and there are plenty of drugs which are available in combination. So I think almost every patient, and then there are, at least in Kerala and many other states, drugs are available from the government for patients who cannot buy their own drugs. And even you have highlighted that now generic preparations are available in special pharmacies where most of the common drugs that you require are easily available. And I think as we have a very good pharmaceutical industry in India, we've also, many of the expensive drugs are available at fairly considerably cheaper prices in India in combinations with effective drugs. So I think though the problems are many, we have many solutions as well. So I think that is the take home today, that though diabetes care seems to be a problem in India, I think there is plenty of solutions. And I think the solutions will come when each and every medical graduate can handle at least type 2 diabetes with a fair degree of confidence. They should be able to, I mean, they may not be all be able to start insulin, but they should be confident in using oral drugs, in controlling their blood pressure, in using a statin appropriately, so that you prevent long-term complications. So thank you once again, Dr. Neeraj, for joining. And I think this has been a very interesting session today. And thank you very much for joining.
Thank you, Dr. Jacob. It was wonderful to have you.
All right. And good night to all those who are listening to us. And I think we'll be